So now let's start with our first panel, which is entitled Planning for Health Information Privacy and Security in a Global Context. I'm pleased to welcome Stan Crowley of Drinker Biddle to the podium to introduce this first panel.
Thanks very much. Good morning. And thank you for the introduction. I'm Stan Crowley, counsel of Drinker Biddle. I'm also a director of the Indiana University Center for Law, Ethics, and Applied Research in Health Information. We affectionately call that CLEAR. And I've had the good fortune to work with Lucia Savage and Devin McGraw as a co-chair of the group started by Devin, the Privacy and Security Work Group of HHS-ONC. And Devin very kindly brought me in basically as her second chair and then abandoned me and went to OCR. And we've not been the same since. So a global panel, definitely on privacy, data security, that's what we're shooting for here. My own privacy journey really started back in 1996 when I was the chief privacy officer at Eli Lilly and Company, and sitting in a meeting with 10 other individuals, all of whom were in global IT. At that time, I wasn't the chief privacy officer. I was just an attorney talking with them, and privacy came up for the first time. The issue was they were going to do a global implementation of SAP, a German-based company that at that time had no privacy controls really set up for a global implementation. We were one of the first global installations of the technology. And as they're talking, I had just read an article about this, EU data protection directive. And so, it came my turn to talk, and I had nothing really to say other than to say, well, we do have to take care of this EU directive issue. And they looked at me and just said, what are you talking about? And I said, I don't know. I just knew the phrase, so I used it. You called my bluff, and so now I've got to figure out what to do about it. And so that started this entire process for the last 20 years, really, of this tension between data protection and data security and data use. And we've been trying to find the balance on that ever since. And while those of us who've been around a long time know better than to say it's a trade-off, know better than to say that it's a zero-sum game, in many ways, it feels like it. And so our panel today is going to talk about their global perspectives. And if they please come up, because I'm out of things to say. And as they come up, I'll tell you, we have Talia Arman from the Ministry of Health in Israel. We have Sheila Colclaser from the Global Privacy and Policy Executive at Axiom. Katie Farrington from the Department of Health in the UK. Chris Ingenci at the US Department of Commerce. And Paul Madden, the Department of Health in Australia. And so we're going to take this global, and we're going to lead off with Talia, who's going to tell us a little bit about operations and things they do in Israel.
Hi, good morning. Good morning. Hello, I'm Talia Agumon. I'm with the Israeli Ministry of Health, Office of the Legal Advisor. I deal with patients' rights, privacy, and health IT, and some other aspects not relevant for today. Thank you for having me. Israel is a small country. We create buzz way beyond our years and size. But Israelis are normal people like everyone. We are aware of our privacy. We do not completely trust the government, and we worry a lot as a people. We also worry about health data, and as a public officer, what worries the public worries me. When it comes to health data, Israel has a few elements that make it interesting for data miners and challenging for privacy advocates. Very challenging. First, every Israeli has a unique ID number that enables interoperable systems that goes with him from birth to death and applies to all aspects of life, not just health. This can be a good thing and a very scary thing. We use this ID number in the health system to de-identify data by hashing it. This lets us kind of track a specific person through the health system, yet she remains anonymous. Second, Israel is a high-tech hub in medicine as well, so most medical facilities and HMOs have electronic medical records for over 20 years. There's an error in the slide. And administrative data over 40 years in some places. We have 4 HMOs, yet one holds about 60% of the population, so our health data is highly centralized. Element 4 is Apec. Some of you who were in the Datapalooza yesterday heard my boss talk about it. It's Israel's health information exchange system. It allows caregivers to view patients' medical information from electronic health records in hospitals and HMOs all over Israel without creating a central database. The Ministry of Health provided leadership, infrastructure, knowledge, and some of the funding to connect all HMOs and general hospitals to Apec. Also, good to know that since 1989, the Ministry of Health has collected de-identified data on hospital admissions, diagnosis, and procedures. And recently, we added to that data from HMOs on community care. And we can align all that by the hashing of the number. So we have a lot of data. It's well organized, it's accessible, and has tons of potential. Now, this is where it gets tricky. Part of my role at the ministry is to be the gatekeeper of all this wonderful data. You call that Chief Privacy Officer. Many want to access this data. My job is to say who can or cannot, why, how, under which terms, what safety measures are to be taken. Well, the question is, how do we secure information without killing all potential of data sharing? And the easiest thing is to say no. Our regulation needs some fine-tuning and innovative thinking to allow me to say yes more often. When I consider it, I have to consider various points of view and interests. My main concern is privacy. That is my job. Other people have different concerns. Our decisions as a government has to be transparent and acceptable by the public. We ask who owns the data. Whoever holds information believes it is theirs and theirs alone. That's hospitals, HMOs, patients, other government agencies. Intellectual property question raised, both about the data itself and about what comes out of using it. Some of our stakeholders in this matter are very strong. They can talk about their interests. Others need me to be their voice. This is what I do. It is highly time and energy consuming to change regulation, especially when we have to balance the need for effective governance and enable and encourage innovation. And innovation, in essence, hates regulation. So what we do in Israel to promote safer use of health data. Our first priority is saving lives. This is why we invested a lot in our National Health Information Exchange, Apec. Now we invest even more to create a unified terminology base that would make it even better. Enabling secondary use of data is another goal. It should be done without breaching patient rights, including privacy. We are now in the process of creating a national de-identifying platform. Once we are satisfied it is good enough to protect privacy, it can be used in all sectors, not just health, and it can help us use data for research, BI, policymaking, and other uses. The Israeli National Council for Digital Health and Innovation has some of the best minds dealing with data, medicine, research, and regulation. I'm a member on this council. It discusses secondary uses of health data and recommends the rules for using it as we speak. Also, 4 teams have started to outline regulation to comply with OECD guidelines recently published, and the task force works with the HMOs to give patients better personal health records with better access to transparency. So to sum it up, everyone wants to receive data, yet won't offer their own. We in Israel want to receive and offer data, dilemmas, and solutions, and this is why we are here. Thank you.
Yes, good.
Good morning, everybody. I'm Paul Madden. I'm one of the Deputy Secretaries from the Department of Health in Australia. Privileged to be here. Thanks very much for the invitation. It's been a great couple of days living and learning through what I'll call challenges as we all exist in a parallel universe. What is we're trying to achieve across the globe just looks so similar. It's amazing. I've got two roles in my job in the Department of Health. One is I'm in charge of information management, otherwise known as the Chief Data Steward for the Department of Health in Australia. The other one is I'm the Program Director for leading the rollout and implementation of the My Health Record system in Australia. So I'm going to tell you about the My Health Record system because it offers some great opportunities but also delivers some pretty good privacy challenges as well. We have a system in Australia called the My Health Record. It is in fact a personally controlled one, and the reason for that is we want to put the patients at the centre of their own healthcare and their healthcare management. We established that system and it's been operational as a national system since July 2012 and it was initially established as an opt-in system. And to opt in, a person would need to go online or on the telephone or in person to one of the shop fronts and prove their identity and then give consent to a couple of things. Number one, to have a record created for them. Number two, for information to be uploaded into that record about their health and clinical circumstances. And number three, for any healthcare provider involved in their care to have access to their record. The main aim of that was to provide access to the person's health information across the whole healthcare setting, regardless of which provider they go to. All of them would be aware of and up to date with what's happening for that particular person. Performance of the opt-in system, been there since 2012. In an opt-in arrangement, we've got 2.7 million people have gone through the registration process and done that consent thing as well. In terms of the performance and what we get in terms of benefits, rewards to the system, 2.7 million people out of 24 million isn't enough for GPs and other healthcare providers to take the time to learn about and get involved and engaged in the system. So we needed to do something different. In late 2012, we did a review of the system, feedback from all corners of Australia, both from Consumer Health Forum, from the Consumer Advocacy Group and all healthcare provider peak associations. Feedback was we had a reasonable and a good start in what we're trying to do and the aims were quite well founded. But the problem was until we got the majority of the population in the system, we weren't going to get full engagement with it. Suggestions and recommendations from both consumers and healthcare providers was tip it from people needing to learn about and then take a long step to prove their identity to get into the system, to make it available to everybody, and they then had an option to opt out if that's what they chose. So the recommendations to twist the system from opt-in to opt-out was considered and agreed by government back in May last year, and in November 2015 we had the legislation amended to allow it to operate as an opt-out system. We're trialling that in 2 locations in Australia, which involves 1 million people, and those people are informed, a letter, an information brochure and online services for them to make choices about whether they wish to stay in the system or opt out. So far the feedback's been very positive from both consumers and from healthcare providers, but the system for them to actually access those records will kick in from mid-July, and people who wish to opt out of that system have got the ability to do so till the 27th of May, and so far we're running just over 1% of people have chosen to opt out, and that's actually declining as well. It actually brings about some very interesting privacy challenges which we dealt with in part through the legislation. Privacy and security is a very, very significant issue for us in Australia, and the trust of the system. I think the quote from Fred You know, data will move as quickly as trust. It's absolutely critical. For people in Australia, they're looking for confidence at every step of the way. The more you know about the risks that exist in the systems, the more you are concerned. So we need to consciously and overtly address those things as we go. The legislation to allow us to do what we're doing comes in two ways. Number one, people are deemed to have given us their informed consent to have a record, to have information stored in that record and for that to be accessed, unless they choose not to by opting out. If they don't opt out, they're able to cancel or delete their record at any time. They have person controls in the system where they can track any time their information's accessed. They can get an alert through their mobile phone or through email. Tells them whereabouts that's been accessed and what date. And if somebody's concerned about that, they can start to raise the alert and the alarm. But inside the law, we've actually stepped up the penalty regime there, again, to deal with the privacy issues. And while it seems like some fairly stiff penalties, and it's been seen by those people who really should be accessing the system as prohibitive, healthcare providers in particular have been concerned that if they accidentally access a record, they'll be subject to some of these penalties. And the operative word in the law is intentional misuse of the information. Now, intentional is judged and monitored by a position we have in Australia, which is the Information Commission, Office of the Information Commissioner, which houses the Privacy Commissioner and other pieces as well. But the legislation and the penalty regime start with cautions on what should or shouldn't be used in the system. We can reject people from getting access to the system. We can fine people and we can fine bodies corporate if they're involved in misuse of an intentional kind, all the way through to systemic and absolute abuse of that information, which can lead to 2 years of imprisonment for the person involved, together with penalties for the body corporate involved. The confidence that we get from the community, it's not one of those things you can set it and forget it. Here's the protection, trust us, it'll be all right. Active involvement, active performance reporting and active management of what's going on there absolutely needs to work. As a central national system which is accessible by up to 500,000 healthcare professionals and a population of 24 million records at some stage, it is an absolute target. So we need to be on our best game, watching, providing surveillance and being up to speed on every possible risk that exists. I'll answer any questions you have during the rest of the panel. Thank you very much.
Good morning. I'm just going to check I've got the clicker working. Hi. So good morning, my name's Katie Farrington. I work in the UK government and I'm the Director for Digital and Data Policy. And the first thing I wanted to say is that being part of Datapalooza has just given me the most enormous lift. It's been really fantastic to be here for the last couple of days and I've learnt so much and I've really enjoyed it. And the second thing I want to say is, as far as I see this debate, it's a triangle. So we have privacy, we have security, but we also have trust. And it's interesting just how consistent that is with what you're hearing from other people. The first thing we need to worry about is that people can trust that their data is secure. So we do have a cyber threat. We do take it quite seriously. Actually, at the moment in the NHS, we're not doing too badly. So there are various attempts to attack the NHS systems. Actually, for the most part, the NHS holds up quite well. The issue we do have, though, is we have loads of variability in our system between, I'm sure this is common to other countries as well, but between small GP practices, small care homes, and enormous hospital trusts, and the level of confidence and capability varies massively. And what we're trying to do there is we're trying to look at the issues so that we've got people that know really clearly what they're expected to do, we've got processes that are robust, and we've also got technology that's secure. and we do still have some unsupported software that we're very keen to get out of our system. The other thing I'll say, and it's very consistent with what you've heard from Paul and from Talia, is that we are also working around consent and trust. I've put up here the front page of the Daily Mail last Tuesday. So that is the second most read newspaper in the UK. It reported a story about the Royal Free, which is a hospital in North London, working with Google DeepMind to design an app to help clinicians to make judgments about patients with kidney disease. The story that was reported was not about technology helping clinicians to make the right judgments, to support the right care for patients. The story that was reported was about unscrupulous profit-making companies accessing whole swathes of patient data going back years and years. And it just really brought home to me how we do still, and we just have to recognize it, there are sections of the public, there are certainly sections of our media that continue to be very anxious about patient data being used for whatever purpose, and we really do need to continue to try and make the case for data being used to support care, to support research, and to support other beneficial purposes. We have made a commitment as a government that people will have the right to opt out from their data being used beyond their other than for their own direct care, and that they should also know what's happening to their data so that we have more informed people making more informed choices. And that's very consistent with what you've heard from other people. And this next slide just takes you through a piece of work we've been doing in the UK. So Secretary of State Jeremy Hunt commissioned 2 reviews around data security and consent. And I've had the great privilege of working with Dame Fiona Caldicott. She's been asked to do 3 things. She's been asked to design new data security standards to apply across the whole of the health and social care system, so right from those little tiny care homes up to those big hospitals. She's been asked to design a method to enforce those standards, and that for me is really the key, to try and make them bite, so putting them potentially into our hospital inspection system, putting them into our standard financial contracts as a way of saying, these are the expectations, you have to meet them, and making them really clear throughout the system. And she's also, the third thing she's been doing is working on a new consent opt-out model for data sharing that is a bit more around the purposes for which data can be used and tries to give people a really simple choice around opt-out. I think we will publish that report before the summer, and we will make sure we share it with our international colleagues who are facing the same issues in very similar ways. And then I think the final set of things I wanted to say, and it's really been brought home to me in the last couple of days, is we've just got such fantastic opportunities at the moment to use health data for good, to support care, to support research, and actually to drive innovation and entrepreneurship and the economy. And the UK government really wants to be part of that. We want to be an attractive place for digital health investment. We're putting in, and George Freeman talked about this on Monday, we're putting in a really significant investment over the course of the Parliament, £4.2 billion to enable free Wi-Fi, enable interoperability, and George Freeman would always describe this as building the train tracks to allow data to start to flow. But I think we're pretty clear that in order to make progress on this agenda, we really have to get that triangle right, the privacy, security, and trust, and we just need to have data held securely, people having confidence that their data is held securely, and also people having knowledge and information about when it's being shared and frankly, for what purpose. So thank you very much.
Thank you. And so we've seen just a wealth of information in the first 3 presentations here, in really covering a huge span, including things like a universal ID, including centralized patient health records, and the security and privacy issues. I want to take it global a little bit and have Kristen comment a little bit on just the transfer, the movement of information and some of the issues that she's facing at the Department of Commerce, and kind of some opening comments about how what her challenges are. Feel free to stay there, up here, whichever you'd like.
Sure. Good morning, everybody. My name is Kristen Jency. I work in the International Trade Administration at the Department of Commerce, and I was really struck by Stan's opening remarks talking about the EU Data Protection Directive, because that's when I kind of entered the scene, and I really do think that was a game changer in many ways, and kind of the reason, the genesis that we came up with one of the key programs we run, which is the US-EU Safe Harbor Framework. And now has become, it will be replaced by this Privacy Shield framework, which I'm happy to talk about a little bit more. But just wanted to kind of, at the highest level, talk about these issues in the global context and what we're seeing around the world. I wanted to point everybody to a really good study that was done in March of 2016 by McKinsey Company, which is, talks about digital globalization and the new era of global data flows. This is a really great study, but it kind of underscores why the International Trade Administration and the Department of Commerce is spending so much time thinking about what companies need to do to comply with privacy and security regulations around the globe, and why this is so important, I think, especially in the healthcare context. But there's a million great statistics and graphics in this report, but one point I just wanted to underscore is that global flows have raised world GDP by at least 10%. This totaled over 7.8 trillion in 2014 alone. And data flows now account for a larger share of this impact than global trade in goods. So this is really significant, and you know, if you look around the world, not just in Europe, you see that issues around prohibiting cross-border data flows, or initiatives, sorry if I lost you there, or initiatives that are saying that, you know, you need to keep data in your own country in order for it to be protected. You know, this kind of goes in the face of the model of the internet and what the technology can offer. So it's been a very challenging environment to try to make sure we find that we can both protect privacy, increase trust, while ensuring that data flows aren't blocked. And just looking around the world, so obviously Europe, a lot of attention, especially with the new General Data Protection Regulation that was recently passed and approved. You know, this will replace the 1995 European Data Protection Directive. It does include a lot of new requirements. It will come into effect in May of 2018, so it's something to really pay attention to. In the trade world, of course, I don't know how many of you are familiar with the Transatlantic Trade and Investment Partnership, but we anticipate that there will be a chapter in that trade agreement on e-commerce and data flows and data localization, some of these issues that we're trying to get at. Just broadly in Asia, we're doing a lot of work, obviously, in the Trans-Pacific Partnership Agreement. That text is available to the public. There is a chapter on e-commerce which includes language on data flows and data localization that's worth taking a look at. And then one of the things that the Commerce Department has been working on very closely with our colleagues in the Federal Trade Commission and other interagency colleagues is this Apec cross-border privacy rules system. And this has been a very high priority for us because really there are 21 member economies of Apec. Wouldn't it be amazing if a company could say, you know, I'm going to meet the set of privacy protections and security requirements once for all the APEC countries. So instead of meeting 21 different requirements, you're meeting one requirement that's good for all 21 countries. That is what we're aiming for. It's a big goal. Right now we have 4 countries that are in that. It's Japan, the United States, Mexico, and Canada. And we're working very actively to target more countries to get them involved in that system, because it's really, not only is it promising in and of itself as a system that will both raise the level of privacy protection across Asia, but also we are working with the EU to figure out if we can make it interoperable between Asia and Europe. And that's really powerful, and I take that as a real promise of optimism that the EU is really interested in this work. I think everybody recognizes that you know, if you look at all the levels of development in APEC, you know, you really are raising the bar for everybody, and that's a very powerful initiative, I think. You know, there's a lot going on with Latin America. Peru, of course, is a member of APEC. Colombia has been very interested in this work. Brazil has a new privacy law. Also, Africa, South Africa has a privacy law that's gone into effect. You know, we're looking at developments in the Middle East. So a lot of work to really think about this globally, to really think about how this impacts companies, and how we can use these initiatives to build trust. One of the, I can come back to this later in the panel, but I did want to speak a little bit about Privacy Shield, and this is the replacement to Safe Harbor. And basically, the goal with Safe Harbor back when the 1995 EU Data Protection Directive was passed was to build a bridge between the US and Europe. So the EU has this top-down kind of comprehensive regulation. We have very strong sectoral laws like HIPAA and Gramm-Leach-Bliley and others protect sectoral information, but we don't have a comprehensive law. So really, the Safe Harbor framework was built to build a bridge between these two approaches. And it was operating for 15 years. It generally went very smoothly, but I think everybody can recognize after 15 years an agreement, it's probably time to update it and ensure that it's modernized. And of course, with the Snowden revelations and other things, there was a lot of concern in Europe about government access to data. So we took it upon ourselves and working with Europe to come up with a new framework. And this is the Privacy Shield framework that we announced an agreement on it in February. It's going through the EU approval process now. We hope that will happen shortly, and that we'll have the new Privacy Shield program running in later this summer. And I can talk a little bit. There is a section on pharmaceutical and medical products that might be of interest to you all, which I can discuss a little bit. But we hope that if we can get this approved and really kind of put more emphasis on our dialogue and our outreach to not only the EU, but also all the EU members, not just the European Commission, but all the EU member states about data protection and what we're doing, you know, that we can really turn the page on trust and work on some of the broader issues to allow us to really take advantage of all the technology and other innovation that's available to us. So those are just some thoughts.
Thank you, Kristen. That's wonderful. And so I'm going to bring Sheila into the conversation as the representative of a global corporation, and talk a little about the things you do at Axiom too. But you know, we don't have a universal ID in the U.S. We don't have a centralized patient record. You see, we'll get into a little bit about the issues with a universal ID, but the work that you do at Axiom and how it addresses some of these topics as well, Sheila.
Today. I work for Axiom Corporation, and they are a global service provider, and virtually every dollar we create is data work. So we have a 45-plus year history doing intensive data work across all industries. We work intensively in the financial services sector, telco, retail, gaming, insurance, entertainment, technology, and health. And of course, what we see, our view is that other industries are much further along on harnessing data and using it to solve the consumer need and the business need. And as we all move into the world of big data, where we're operating on these big data lakes, and we're extracting insights and driving good into our customer sets and creating economic value, I think that the number one takeaway, if I would just summarize for a moment, all of us have spoken about trust. And trust is at the foundation of every human relationship. It's at the foundation of my relationship with my best friend, with you, with your spouse, with the brands we choose to interact with our governments, and with our healthcare providers. And to have trust, think about it for a moment. If I trust you, things go very, very fast. And if you make a mistake, I'll give you a chance to explain, and we can probably move beyond it. If I don't trust you, things go very, very slow. There's extreme reticence until we build up the trust. The foundation of trust is this idea of ethics. So in my shop, I like to talk about the ethical use of data. And in the world of big data, to do ethics means you've got to go from a policy construct where you take the important HIPAA constructs or the requirements in Australia or in UK or in Israel and in the US, and you translate from policy requirements down into operations at the engineering layer. And that's a very aggressive requirement and piece of work. And so what I want to kind of focus on of this extreme piece of work that we do to translate all of that into the engineering layer is talk about identity for just a moment, because I think that is a challenge for us around the world, where you need to make data actionable, you need to be able to pull together different representations of the same person so the data can pull and you can get an accurate view, right? This is this idea of a national identity number. In the US, we have something many people think of as national identity number, the Social Security number. It's not so much, right? There's a lot of duplicates, there's a lot of error, there's a lot of purposeful use, fraudulent use of SSN. In other countries where they have a number, it may or may not, and we see these numbers, so I can tell you from our view, we see them have very similar accuracy issues that we have. So when you're trying to arrive at identity or entity resolution, I want to introduce this concept of the data work. You've got to have a means to fix the data, to hygiene it, to transform it, to parse it, to get it ready to integrate into a single view of the user or the person or the identity. So it takes a lot of layers of technology work, fixing the data, then you bring it together, and then you lay on an identity link of some sort. And once you arrive at the accurate view of person, and you put your link, which is what we call ours, you put your link. It might be a combination, and here in the US, it's an easy example. SSN, Social Security number, might be a part of that. But you need a lot of other data and massive algorithms that act on it to create the view, put on the accurate link, and then once you have that, you can either use it in a personally identifiable format for all kinds of amazing and powerful outcomes. Then, if you need to de-identify or anonymize or pseudo-anonymize or aggregate, whatever you need to do, then you take your precise, correct view of person and all the attendant data, and you go through some kind of cryptography to treat the data. And this is what we all hear about as hashing. Now, I'll tell you what we know in the Axiom world. The strength of the cryptography, how you then render the data de-identified, the strength you put behind it, really depends on the sensitivity of the data and the sensitivity of the use, because data should be use regulated. So we have a range of cryptographic treatment that, depending on the sensitivity, depending on the entity we're going to transfer to, we apply a strength. And there are a variety of cryptographic recipes. Some we intend to be locked and unlocked, so they're reversible with a set of crypto keys. And some we put such extreme rigor on that we intend them to be irreversible no matter where the data flows. And that takes part technical control, right? A technical mitigation for all the attendant harms and some administrative controls. But you've got to plan through that process very carefully. And Stan, I don't know if we have time to talk about it, and maybe we can circle back later, but the process by which you really examine, again, at the engineering layer, the implementation design, so you get it right every time, you identify all the harms, and you have mitigations for those harms. You articulate the values, so you make sure you're not reducing or eliminating value in your engineering design. There's a very specific process that brands go through, or as a commercial provider, we apply to the solution design, and we do this around the world. We have a lot of challenge, if I might just have another minute to talk about the challenge. When we're trying to create a global solution and we run into our clients, we have to navigate this, these feelings and the laws that seem to bind forced localization. And it's a challenge for a brand that is trying to optimize their spend, optimize their technology treatment, and optimize outcomes of the data. It's very hard when you need or you want to achieve a global solution in a centralized location, so you don't have to have technology stand-ups in this country and in this region, and you keep it isolated. You can't take advantage of some technology dollars and some expertise. It's a big challenge for global companies. However, this is what we have to navigate with our global clients when we're doing the global stand-up. We have to replicate a capability. It gets very costly for each of these countries. We're very watchful and optimistic about the Privacy Shield. That's a big region for us. We're very optimistic about the Asia work because that's a big geography for us. But we have clients and we are doing global stand-ups that pull data from all of these regions, and our big thing is accountability. To be sustainable and for us to be a commercial provider that's sustainable, we have to be accountable, which means we have to do this engineering layer examination, do all the data treatment, get it right in every instance, and then navigate when we need to do de-identification, pseudo-anonymization, or aggregation, or when and if we can work in the PII. And that, I'll pause for a moment. That's a lot of content, but that's, as a commercial provider, really what we're grappling with in the global data flows.
No, that's fantastic, Sheila. Thank you. And you know, as a moderator, I usually have a vision of how the panel is going to unfold, and usually when the panel unfolds according to my vision, it fails miserably. So the good news is that we're completely off script at this point, and I really like this idea. So my panelists are going to have to respond to this a little bit, but I like the idea of, you know, we've got trust that has been identified as a theme that's running across here, and I thank you for that. And I think that's exactly right. And as we think about the trust in each of your circumstances, Paul, I'd like to turn back to you. It's interesting the work that you've done in Australia on trust and how you started in one way of an opt-in and moving now potentially, at least testing the grounds for an opt-out, and how that trust dynamic is working out potentially, or what the issues you're looking at in Australia.
So I think when the system was first put in place, it was called the personally controlled e-health record. And the person controls there were for them to impose their own trust levels on the system. And this allowed people that they could curate their record. If they saw something on the record they didn't want others to see, they could delete it. They could set things so that one doctor could upload things, another one could see them and no one else could. Or they could say everybody can see them except for that institution or that particular professional. I guess the balance between what is my data there for and what are you going to use it for, and how much of that do I want to control and how much might I want to conceal, is played out pretty well, because I think it's less than 0.1% out of the 2.7 million have actually exercised any control to limit what people can see.
Can you say that again? What was it?
Less than 0.1% have exercised control on what people can do with their record. So for most of those people who have registered, they've given the consent for record to be created, have things uploaded and to be viewed. And less than 0.1% have put a control that says one of the people in the community can't see it, or one organisation can't see it, or have even deleted documents. And I suspect that the small number of those who have done it on the basis that our policy said, we will have a system that allows you to do this. And a lot of people went in to prove that the system would allow them to do it, which is really interesting. And I think the shift to opt-out, it's not a case of, it could be misconstrued as it's too difficult to communicate to the whole population to say you need one of these. Therefore, you go and register and take the time to do it. By turning it to opt-out, we have to go through all of that communication education process because we, at law, need to inform people what they will get if they keep a record, the access to the benefits, how we'll treat their information, how it'll be exposed, how it'll be controlled, how it'll be secured, and what they won't get if they choose not to have one, which is they lose benefits of their information being used to make more precise decisions about their treatment and their ongoing illnesses. And I think, again, around about 1% of the communities in the opt-out trial, so 1% of 1 million people, have said, I either don't see the need for this or I don't trust you. Now, how that trial goes will determine how far we take the rollout on a national basis, whether we cap it at the trials and leave it as is, or if it's a success from a community perspective, we'll go further to a national rollout.
And Katie, you kind of kicked us off on this trust concept as well, and I like the triangle. I would just make one amendment to that as privacy, security, and use kind of makes up the trust triangle in my head, But I think that if you've talked about this, it's a little bit different in the UK from what Australia has done. Maybe you're the forward-looking of what Australia can look forward to on an opt-out basis.
Yeah. So we are very much looking at opt-outs rather than opt-ins. We're just about to introduce a new one, which again would be an opt-out rather than an opt-in. I do think, though, there is something about consent and consent actually being the sort of silver bullet. And if you can get consent, that should really be a liberating factor. So I can imagine a world where we have a situation in the UK where you might generally set your opt-out saying, I don't want to share my data for research, but if, say, you've got a condition like diabetes and you want to participate in a research trial, you consent to opt in to that research trial, and that might kind of trump your probably not a great word to use in this country at this moment, but that would override your general opt-out. And actually, one thing we've done in the UK, which is really interesting, is doing a piece of work around genomics, where we're getting 100,000 people to sign up to map their genomes, and for rare diseases and for certain types of cancer, and that is all on the basis of consent. But the consent process at the beginning took 2 hours with that person, and we've now just about managed to strip it down to 1 hour per person, which obviously you can do quite well where you've got small cohorts with rare diseases and you can have that one-to-one conversation, but you're looking at 50, 60 million people, then you can't communicate in that way.
That's fantastic. Talia, as we think about the issues that you're facing with the universal ID in Israel and in the US, the distrust, the worry about privacy and security, and hence the erosion of trust if there is a unified identifier, a universal identifier. How have you addressed that in Israel? Have you found a way to still maintain trust of individuals, or the steps that you've taken with the universal ID to help it make it establish trust across the system?
Well, I think Israelis grow up with the ID number since the beginning of the state. So this is not something that is in question. But yes, they do ask themselves what is done with the information, who can get data, how does that transfer from different authorities, different agencies in the government, or who does it go to outside of the government. And we solved the problem, I'm not saying 100%, but the concerns about privacy in the data that the Ministry of Health collects for policy making and health planning, and this solution of hashing the ID number in a certain irreversible algorithm that allows us to see exactly the process and big numbers that are going through different stages in the health system, but without revealing the identity of the person. I think this is relatively well trusted. We are working to improve it and working to make it better because technology is improving and maybe hackers are improving and we want to be better at what we do all the time. But I think we are relatively in a good place, trust-wise. There are always people who are not satisfied. There is no 100%.
Great, thank you. And so as we think about, again, trust across the system, I think use and security is key. And Kristen, in a lot of your negotiations, the use of the data obviously has been at the forefront as countries who are trying to trust data across to the U.S. are worried about the potential use of that data that may in fact violate that trust. And so how have you address that, or what concerns do you see with that?
Sure. Well, these themes about transparency and accountability, really, there's a lot of the updates to the Safe Harbor framework are trying to tackle those issues, increase trust and ensure accountability. And that was done in several ways. Are you referring in the commercial context, or are you more referring in the national security context, or both?
It can be either.
Yes.
Whichever one you think is relevant. Obviously,
Sure.
National security comes to mind.
Yes,
as
this has obviously been a huge theme for us. But there are, one of the things I really encourage folks to do, and I know folks are not always that interested in reading a bunch of government documents, but the actual Privacy Shield framework, which is contained in this exciting binder, has a really, I know nobody wants to read bureaucracies, but really there are two letters in here, one from the Office of the Director of National Intelligence and one from the Department of Justice, which gives a great summary and overview of the protections and limits to government access of data in the United States. And this is very recent. It's probably one of the most comprehensive and recent summaries you'll find of what protections are built into the United States system in terms of limitations on surveillance. So those, I think, we had, as part of our negotiating team, the representatives from ODNI and Justice there to describe what our protections are and to educate them about what's happening. On a very concrete note, one of the changes that's part of the Privacy Shield framework is this idea that there will be an ombudsman at the State Department that will coordinate when there are complaints. So if an EU citizen has a complaint or concern about how their government data was accessed by the U.S. government, there's a person they can contact at the State Department, a very senior level official that is committed to reviewing and researching this complaint. So that's very, very new. But I think one of the key differences between the Safe Harbor and the Privacy Shield framework, and really why the European Court of Justice struck down Safe Harbor, is not because the principles were faulty or the program was poor. It was because they said when the European Commission gave the United States the Safe Harbor framework adequacy, which is what it needed in order to operate, it has to be deemed adequate. We're going through the same process right now to get Privacy Shield and adequacy finding, was that the Commission didn't consider both the commercial context and the national security context. So that's why the court found it invalid, is because we weren't considering the entire picture. We just looked at the commercial. So that's a huge difference between Safe Harbor and Privacy Shield, that now we're looking at the whole context, and that's why this framework document is so different, is because it does include those letters from Justice and ODNI to address the security side.
Fantastic. And so as a global company, as I sit and I look and I hear this conversation going on, and I have a sensor, centralized device, a wearable, or some type of a potential healthcare device, a pump or an implantable, and I'm trying to roll out a global product, and I listen to the different jurisdictions and the way that they handle health records and opt-in and opt-out, and the different criteria within local law. And I realize there isn't a standardization that's been created yet. There aren't standard definitions. Who here can define for me what de-identified means and trust that it applies globally? Yeah, that's right. No one would raise their hand because there is no such thing as a global definition for de-identified data. And so at some point, if we're going to have a global health information ecosystem. We're going to have to establish global definitions at the very least. I stop short of saying standards. I'm just talking about making sure we're all talking about the same thing. And so as a global company entering this environment, I have to now draft privacy statements that comply with every local law where my devices are going to be utilized. And then they have to comply with the transfer requirements of that local law when the data becomes global. And so it's a little bit daunting, to roll out a single product, let alone multiple products in a health information, in a health ecosystem like this. And so, one of the, Sheila, as you think about how Axiom approaches this and the data inputs from various regions and sources, I know you undertake a fairly significant PIA. So we've got we only got about 5 minutes or so left in the panel, so just a couple of minutes on the process, and then 1 minute. That can't possibly be true. All right.
So what Stan's talking about is this thing that we do called, it's a privacy impact assessment, but it's more than that. It is a comprehensive, contextual, ethical interrogation. The idea of ethics is you do what it takes to get it right, meaning the outcomes. So it's legal, it's just, and it's fair. And in the global solution, where you're drawing together these data streams for a single commercial entity that's operating in the health space using this sensitive data that relates to person, and they're trying to stand up a solution of their data around the world that delivers good outcomes, you've got to do an event that translates the policy construct, again, into the implementation. You've heard it called privacy by design or privacy engineering. We don't do it in a vacuum. You have to have different stakeholders and expertise from your enterprise. You need a privacy person who's going to translate the meaning of the different definitions and the different legal constructs. You need an actual person, a legal person, to help with the contractual translation. You need a security specialist to layer on the security controls and the considerations. You need an engineering stakeholder, and then you need a use specialist. The way that once you surface all of the facts about the data stream, and then you understand how you're bringing the data together, you're translating it, you're bridging it, you're analyzing it, are your analytics right? Is the data accurate? Are you achieving accuracy? And then on the outcome, are you measuring for impact? Have you anticipated all the harms, the potential misuse of the data once brought together, and mitigating those so they don't happen? And are you enabling the value, and are you articulating it? So it's a very complex piece of work. It takes a lot of man hours, but this is the way we stand up solutions, because in the world where we're data-driven everything, and as a society, I'll quote the famous William James, the father of American psychology, people tend to become what they think, and as a society, the same is true. We're becoming what we think. We are becoming data-driven everything. How many people have a smart device? And how many apps are on our device? And how does that assist us in our daily life? And if you wear a health device, a Fitbit, a sensor-embedded shirt, sensor-embedded shoes, or you drive a brand new car with a retinal fatigue sensor, think about how that data could be used for good, could be used for bad. But this is a global issue, and divining or ensuring the value to each of our consumer lives and our society as a collective whole takes a very deliberate methodology to get it right every time.
Well, I'm crushed that I can't ask additional questions of our panelists. I was wanting to dive in longer, but please join me in saying thank you to them for all their work. And we'll hand you off to the next panel. We'll go up that way.